Our next speaker is Dr. Stephen Sands, is currently professor of the Psychology Department of Psychiatry and Pediatrics, Behavioral Sciences, attending psychologist, director of pediatric neuropsychology. We keep going, at Memorial Sloan Kettering Cancer Center. He received his BA in psychology at the University of Michigan in Ann Arbor, his doctorate in psychology and child psychology at New York University in New York, his internship in clinical child psychology at St. Luke's Roosevelt Medical Center. He did his fellowship in clinical neuropsychology at Memorial Sloan Kettering. He has extensive experience working with pediatric patients who are either chronically or acutely ill, ranging in age from infancy through adolescence and into adulthood. He has been at our conference several times. He also spoke with the survivor group yesterday, and I know we have a lot of new families here, so this may be a repeat for those that have been here, but we also have a lot of new families that I thought it would be an interesting, talk for you to hear about the different problems and situations that come up at school and learning issues and things for children with neuroblastoma and other cancers. Dr. Stephen Sands.
So today I wanted to talk about the neuropsychological, social, emotional, behavioral aspects, impacts of treatment for cancer, and then what we've done so far to try to identify who's at risk, but also what we've done so far to try to help them and what needs to be done in the future. So in terms of neuropsychological testing, it could vary from bedside for an hour, 30 minutes, to literally 6 to 8 hours worth of testing. I know many of you probably have had your children tested. The idea being that we want to make your child feel comfortable, at ease, that there's no trick questions, we can take breaks, they can ask questions, that there's nobody who's perfect at everything, no one who messes up at everything. We all have things we're good at, all things that are hard for us. And then we just want them to pay attention, try their best, and really elicit their best performance, and to be able to say, these are all the things that you're really good at, and these are things that are hard for you. And when you get stuck, here's how you can get unstuck, and here's how we can help you get unstuck. So that's the frame, the context of the person you want your child to be tested with. So if it needs to be broken up into 2 sessions of a couple hours or 3 sessions, so be it. The aspects, I just wanted to take a moment so you can understand the results and what they're doing. So when you talk about IQ, everybody says, what's my IQ, what's my IQ, or what's my child's IQ? And that's rarely meaningful because for kids, there's 5 areas, and for adults, there's 4 areas. And it's verbal abilities, nonverbal abilities. They call it working memory, but it's really paying attention to details. And processing speed, which we will talk about, but I'm belaboring this because it's really important to get past what's my 1 number IQ, because the 1 number IQ is only meaningful if all those areas are the same. Like you have a 10, 10, 10, 10, then a 10 makes sense. But if you have a 6, an 8, a 5, a 2, and a 1, that's where the story is, not what's that number. So it's important to look at, again, verbal, nonverbal functioning, attention, concentration, and processing speed, which we'll talk about in a minute. Language functioning, expressive, receptive language. For younger kids, receptive is first, and then they may be delayed, or expressive could be later. Academics for math, but also, reading, written expression. Attention, concentration for what they see versus what they hear, because that could absolutely be different. That's important to know. Visual, spatial, etc., sensory motor. But learning and memory is also interesting for what they see versus what they hear, because we're trying to understand how children learn best. And do they need information repeated verbally, contextualized, or are they better with visual memory that's repeated? Executive functioning is fascinating. A lot of times kids don't grow into those difficulties because they don't need the ability to use their frontal lobes until adolescence, early adulthood. But that's basically multitasking, being able to pay attention, not get distracted, or sometimes shifting. And essentially, what's the problem? What are some solutions to it? Let me pick one. And importantly, let me monitor if my approach is successful. And if it is, great. If it's not, then let's pick a different approach. And then social, emotional, behavioral is at the end of the list, but is as important as anything else on the list. Because if someone is anxious or depressed, it's going to pull everything down. So it's really, really critically important. So in terms of neuropsychological late effects, this slide is medical risks, and the next one is demographic risks. So under medical, any treatment that essentially affects your central nervous system, your brain specifically, or if someone has relapse and requires further or more intensive treatment. Oh, thanks. Never mind. Okay, cool. I'll remember to do that now. Again, affecting your CNS or having a relapse. And then the modalities like surgery on your brain or spine, cranial radiation, higher dose would be more neurotoxic, wider field would be more neurotoxic, so focal RT would be less harmful than whole brain or craniospinal. Intrathecal chemotherapy goes into your spinal canal and passes your blood-brain barrier on purpose, so that would go right to the brain. Chemotherapies such as cisplatin, carboplatin, and vincristine, we'll talk about in a minute. The platinum-based, obviously, you know better than anybody, the impacts on hearing, and vincristine for peripheral neuropathy. And then bone marrow transplant is on here for TBI and high-dose chemo. But I will say that there are very few studies that say having gone through a bone marrow transplant is neurotoxic to your brain. Absolutely, TBI to your whole body puts multiple organs at risk, and you'd have many late effects, you know, cardio and many others. But the actual bone marrow transplant and high-dose chemo, there's maybe one or two publications, you know, et al. that discuss and talk about late effects for the brain. And I'm happy to talk about that further with you afterwards if you want. Demographic risk factors, child characteristics, young age of treatment. There is no safe age, but younger generally is more difficult in terms of the developing brain. It's also important to recognize, and you hardly ever have testing before someone gets diagnosed, so it's really hard to ascertain clearly. But cancer doesn't, there was a catchphrase I had for that, but basically, discriminate is the word I was looking for. So cancer doesn't discriminate. Some people have pre-existing difficulties beforehand. They would have had reading issues. They may be delayed, may have math disabilities. There's no way to know for sure, but clearly how someone was or how they were going to be is a factor to consider, particularly if there's a family history of ADHD, family history of reading disabilities, etc. So again, cancer doesn't discriminate, and you have to be mindful of kids who've had, you know, issues or difficulties before illness. And then time missed away from school and when. So I know many kids with neuroblastoma get diagnosed early. Similarly with leukemia is early, so a lot of these kids will miss preschool, aspects of kindergarten, and principals will say, oh, they can go to first grade, they're fine, we'll keep an eye on them. And that's not always the best plan because you know, sometimes at the end of first grade, guess what? They have to repeat first grade. So, okay, now it's all right to be too old for first grade, but why didn't we put them in kindergarten in the beginning? Because they missed it initially. So psychosocial factors are family, personal, and community support are absolutely critical. Getting support from people's families, their friends, and the community is really, really important to be able to keep your strength, your focus, your persistence, and your ability to be there for your child. And we take it for granted, but many folks don't have that. They're single parents, they may have come from another country, and having another spouse, having friends to help you, people at church to help you is really incredible. Differences in coping and resilience, again, with that cancer doesn't discriminate idea. So people bring their strengths, pre-existing, and weaknesses to all situations, weddings, funerals, bar mitzvahs, cancers, diagnoses. So the strengths that you had as a family, the strengths you had as individuals, you retain those and you bring those to bear in these situations. Similarly, if you've had difficulties with your child or with your spouse or anxiety or whatever the case may be previously, it's going to be there during the treatment. Cultural issues, if somebody's English is their second language, that's really, really difficult. You can imagine the scenarios where a doctor comes in and uses the patient's sibling as the translator, and obviously that's, you know, woefully inadequate. And SES, unfortunately, is really critically important in society. I wish it weren't, but access to interventions, being able to pay for private schools, being able to pay for private therapy. So common neuropsychological patterns include, and again, this is not ironclad, some people don't have all of these, but the common clusters are difficulties with sustained attention concentration. We all space out, in our lives. I'm sure now you're thinking about, oh, what time is my flight, or where do I want to go for brunch or celebrate? I got to get that Hallmark card for my wife that I forgot to get for a week earlier. But kids in school tend to space out more, and if you're paying attention to the teacher 60% of the time, it's going to be really hard to remember more than that of what they're saying. So you're limited to your sustained attention concentration. Processing speed we measure by timed paper and pencil tasks. In 2 minutes, how quickly can you fill stuff out? But it's not like, okay, he or she is a slow writer. It's slow processing speed for thinking, problem solving, reading, and yes, putting answers down on paper. And then fine motor dexterity, probably more so for brain tumor patients, but I put that up there as well because kids are typing and writing. So it's really because of those deficits that you start to get secondary deficits like lowered IQ, because I was telling you the factors that go into IQ. So 2 of them are processing speed and attention concentration. So if those are declining, that's essentially what's pulling down your IQ as opposed to other aspects. Academic achievement can involve mostly mathematics for many cancer survivors because it's a right hemispheric task, and many of these chemos and treatment tend to impact the right side of your brain. However, in the next slide, we'll talk about hearing difficulty. And yes, there is evidence to look at, not for everybody, but those who have difficulty hearing are delayed in reading. So I keep academic achievement generalized. Learning and memory for generally, again, right hemispheric visual memory, but there are kids who have difficulty with verbal learning and memory. Visual motor and executive functioning, we talked about that usually comes on board, it becomes myelinated sometime between 12 to 22, 24, and it's unclear if your brain is biologically driven to start myelinating then, or it's because the tasks in high school of multitasking and projects pull for that to become myelinated. So this slide was devoted to hearing loss, and I have to remember to do both. So again, I know you're clearly aware of many of these aspects, but just to review the literature, the exposure to platinum-containing chemotherapies, including cisplatin, carboplatin, can result in the destruction of cochlear sensory hair cells, leading to the loss of high-frequency hearing greater than 200 hertz. And yes, it can, does not always, because I was meeting with the adolescents yesterday, and definitely, clearly, some had language delays, reading delays, but not all. Verbal abilities, reasoning skills in young children, giving the timing of the acquisition of language, around 1 to 2 is when you start to acquire language, and if you're receiving chemotherapy during that time, it could absolutely delay it. Those with hearing loss, in a particular study by Gurney, had twice the risk for lower reading, math, and or attention, as well as special education needs than those without hearing loss. So clearly a salient risk factor. But at the same time, the same article by Gurney says that the self-reported quality of life was within the normal range based on questionnaires sent to 137 neuroblastoma survivors from 2 COG studies. So yes, there's documented risk factor for lower reading, attention, special ed than those who don't have hearing loss, but their reported quality of life was actually similar. And we talk about, as neuropsychologists, okay, get an FM buddy, teacher will use it. And yesterday was really illuminating on a couple of aspects. One was that sometimes teachers don't use it, or kids feel like they can't hear their peers because the teacher has it on, and then may forget to turn it off, which leads to other problems. But also what's understated is the social aspects of the hearing loss, where yesterday they were talking about not hearing kids, maybe kids will whisper to them, tell them something, oh, tell me again, what'd you say? Oh, no, don't worry about it. Or they're in a conversation with a bunch of kids, background noise, and they have no idea what's going on. They're kind of laughing along with people or nodding and really missing out on so much socially. So it's not just about hearing the teacher. It's really about how much effort and work it is to maintain social relationships when you're having trouble hearing, excuse me. And since I've been back at Memorial Sloan Kettering, Opsoclonus, Myoclonus is a syndrome that impacts approximately 2 to 3% of patients. I've wound up seeing a fair amount recently and having a renewed respect for this syndrome and the impacts. It's an acute neurological disorder. You guys can just yell out and be like, slide, and then I'll note it. Okay. All right, sorry. That's totally fine to yell out. Acute neurological disorders that affects approximately 2 to 3% of patients with neuroblastoma, characterized by involuntary chaotic eye movements, myoclonic limb jerking, ataxia, which is unstable gait, and irritability and mood in the first 2 years of life. But I wanted to point out to you that the long-term outcomes vary by study. So one study from '94 identified persistent delays in learning or development in 9 out of 10 after a mean follow-up of 4.5 years. So a few things. One, 9 out of 10 is obviously 90%, but it's a small number of patients in terms of being able to conclude this as a fact. And then in contrast, Hayward looked at 11 patients followed for a mean of 7.6 years, which is clearly significantly longer. They found that while the neurological exams were often, not always, abnormal, half of the survivors were functioning within the average range on testing. So the theory here is that it takes time for the symptoms to abate, and not for everybody, but clearly it's not a permanent condition. I wanted to also highlight a few studies that are on neuroblastoma. Some, as this one, include high-risk neuroblastoma. Others just talk about neuroblastoma, kids who go through and are more fortunate. Oh, you guys didn't yell, sorry. All right, cool. 16 high-risk neuroblastoma patients were tested 6 years post-treatment. Again, I want you to be mindful when you look at research, 1.6 to 13 years is very, very wide. In Boston, half received total body radiation. They were more likely to have stage 4 neuroblastoma. No differences between groups on cognition and behavior between those who received TBI and not, and that speaks to the issue about the transplant that I was mentioning to you. Above average verbal IQ for half, and full scale IQ above average for 46%, which is fantastic. 94% had superior performance on one of the tasks. 69% had superior performance on 5 or more, and that their academic, physical, and social functioning was within normal limits. And again, this is for high-risk neuroblastoma. So the question was, why did these kids do so well? There's no one answer, but potential hypotheses include treatment during preschool years may stimulate language and socialization through increased adult interactions, because I know these kids obviously are with you and other nurses, nurse practitioners, and really are in a very language-rich and stimulation-rich environment. Hearing status in this study didn't impact verbal development, as these patients were corrected with hearing aids or high-frequency hearing loss only. And that high-frequency loss makes me think of one thing I wanted to add, that it tends to be people talking in the background of a restaurant, of a classroom. If the radio's on in the car, no, can you turn that off? I can't hear what you're saying. Getting the TV on in the background. And we like to think that, oh, our voices are deeper, one-on-one, so it's better, it's okay. But that, just to be mindful of what I told you earlier, that these kids struggle in social situations, in classrooms, and how often are you one-on-one in a quiet place? I think one of the few places is when I'm testing them. I make sure it's quiet. But other than that, it's really hard for them. 57% of parents who agree to participate, so not all, roughly half, perhaps they have more availability, more time, more financial resources, social resources to participate in the study. And again, socioeconomic status is highly correlated with overall academic achievement. So that's one hypothesis. 50% of the parents receive post-high school degrees, getting back to genetics of IQ, and 75% females in the study versus 25% would be a nod to women being smarter than boys, right? Because they stack the deck here. A different study from 2005 looked at 63 advanced stage neuroblastoma, stage 3 and 4, from Memorial, with a mean age diagnosis of 3. And again, I'm sure there weren't, this is a range, so I'm sure there weren't very many people that old, but that's a huge range. Standard protocol, again, of radiation to the primary site after resection and chemotherapy, which is not something that's as common now. Radiation to the abdomen, chest, cranial brain, yes, it was only 3 out of 5, but I would say that the orbital skull, 12 out of 15, photon radiation will hit the target, but then go through to the brain. There are newer technologies proton in particular, and I didn't include slides because it's not as relevant, but I'm happy to talk to you about it. But I'm positive that these people got photon. So if you're getting brain, you're absolutely impacting your brain with radiation. But if you're getting orbital and skull, there absolutely is radiation going through to your brain. Chemotherapy included these agents. So in this study, in contrast to the thanks. Thank you. In this study, in contrast to the one I showed you prior, 62% had hearing loss associated with cisplatin. There wasn't a dose-dependent relationship that those who got more had worse. It was just that if you got cisplatin, and half had loss within the speech range. 16% had visual problems, with majority receiving orbital radiotherapy for preorbital disease. 13% had neurocognitive problems, low IQ or ADHD, and half received cranial RT. Half had autologous stem cell transplant, and none had TBI. So in terms of developmental expectations, some of this was already presented to you, but I just want you to be thinking, because there's many different age ranges of children here. There's younger kids who are still on treatment. There's older kids who are off treatment. So just to be broad and make sure I'm covering the base for everyone here. So grades 1 to 2, roughly core academic skill attainment, phonological processing, rapid naming of colors, shapes, letters, numbers, socialization. In contrast to, we were talking about the shift now between grades 4 and 5 is instead of learning to read, now it becomes reading to learn. Here's, short books, read between the lines, what's the author's intent, what's their mood, write a little essay on it, and all self-monitoring. I'm getting better at this. Grade 7 would be changing classrooms often now, multiple demands, expectations for planning, time management, which is a new skill they hadn't had to do before, less teacher involvement and support on purpose, and peer pressure, which is not to be understated. And we'll talk about in a minute about quality of life. Kids who've gone through treatment for neuroblastoma, struggle to fit in and do the same things, run around on the soccer field, go to the mall, starting to get your driver's permit, etc. High school and beyond, academic pressures, increased workload, post-secondary planning, dating and sexual relationships. Also intimacy, we'll talk about in a minute, clearly is important for everybody, and is something that many, not all, neuroblastoma kids struggle with. So the interventions by age and development are for school. I just wanted to take a minute to explain this to you. If you know about it already, that's great. But when kids are on treatment, there's no question that both their eyes are on treatment, as it should be. My role is to have one eye on treatment, but also help have one eye on the future in school, what's coming next, and that at some point you need to start having one eye on the future in school as well. So just to be clear, an IEP, in my mind, is more beneficial than a 504. There are advantages of a 504 plan. It's basically a handshake. It's quick. It's one sheet of paper, and it can work. But it's not a legal document. IEP is a legal document that generates state and federal funds to provide your child with whatever he or she needs. And they have to do it and comply. And your child meets criteria as other health impaired, not that they're smart, not smart. It's other health impaired. It's broad. It doesn't matter. It's just a gateway classification. As you know, you have an IEP meeting scheduled every year, but you can request a new IEP meeting at any time by simply saying, I would like to have a new IEP meeting. You don't have to wait. Also, in terms of testing, you can either get your child tested through the school, and that would be IQ, academic achievement, a little bit of how they're thinking and feeling. Clearly, there's lots of other things that aren't on the school list. They don't have the time or the training to do the memory, attention, executive functioning, other important aspects. But you can have either an outside psychologist, neuropsychologist, or the hospital do the second half, or if you feel more comfortable and live near a hospital and won't require multiple trips, you can have the psychologist at the hospital do all of it. But what I meant to say to you is that if you don't say anything to the school, they have to every 3 years retest your child. But you could ask for your child to be tested every year. It's your right to say, I want my child tested every year. They're young. I want to know what services are working. I want to know what's not working, and I want to modify the IEP every year based on how he or she is doing. And then the other thing I just want to say in my pitch that I say to all parents is the law protects your child. The law does not protect the school. And the school can say, oh, we suggest this, this, and this. And you can say, thank you, that sounds great, and maybe it is. You're allowed to say, let me sign that I was present here. Let me think about it. Let me run this by their doctors at the hospital. You can come back and say, speech and language once a week is not enough, which it's not. You can't really get much done in once a week. I want twice a week. I want 3 times a week. Also, it could be 4-to-1 ratio. You can say, you know what? I want twice a week, and I want one can be 4-to-1, but I want the other one to be 1-to-1. And there's a whole host of things that your psychologist at your hospital can walk you through what to ask for. But the main point is I want you to walk in there feeling confident that the law protects your child and that you will advocate and fight for what you want, what you think is in your child's best interest. And the end game is to have a mediation. Is the school recommended mediation, which is sit down. It's a waste of time at the school because they don't agree to anything. And then arbitration is in front of a judge who doesn't work for the school district. So just to know that that's the route, not that you have to go there. Many schools will bend over backwards for your kids. I'm not saying it's adversarial, but I want you to feel comfortable going in. Adolescence is behavioral emotional issues, study skills, organization, planning, and there are specific recommendations that are at the end of a neuropsych report that go over all these. And then high school and beyond, self-advocacy, college support, vocational training. So along the lines of interventions, what we can do, there's roughly 2 aspects. One is behavioral, and one is medicine. So under behavioral, this is all with the caveat that this is the holy grail. This is like we have no idea what works, and we're trying this. We figured out what the late effects are that I presented to you. We're trying to figure out who's at highest risk, but we're also trying to figure out what to do with these kids who are at highest risk. But what we've learned so far is that behavioral now involves computerized programs like CogMed, which is basically like Lumosity, except for kids. I'll show you that in a minute, to train sustained attention, concentration, working memory, and physical exercise, which I'll talk to you about in a minute. And then pharmacological, which is medications, like methylphenidate, Ritalin, or Provigil, and we'll talk about that briefly as well. So the idea about computerized training is it can theoretically be helpful because it's completed at home. Earlier on in the field, we used to have kids come in for cognitive remediation, and can you imagine, I have no idea how they pulled the study off. Having survivors come back twice a week to the clinic for an hour each is really a hard task. So conceptually, having kids do work at home on the computer, also you call in and coach them and help the parents coach their children. They don't have to come into the clinic. It allows for more intensive targeted practices because as you get better, it gets harder. Disadvantages, it's not currently well studied, and it's expensive if you're not in a research study. So just really briefly, CogMed has 2 versions, 4 to 7, 25 sessions, 15 minutes each, 8 activities, predominantly training sustained visual attention. Same thing with 7 to 17, very similar visual and some verbal short-term memory and working memory. So this is what I wanted to show you, is that a couple of things. This is the research on computer-based. A few things. 1, 9, 23, 20, 60. This is a goal. They've accrued 10 so far in COG, so these are very small numbers. I hope you can appreciate that. And then here's the software that 80, 85%, they finish it. It's not as exciting as Xbox, understandably. And then near is yes. Near means when I test them on attention concentration tasks, they do better pre and post. But far is what was really important. Does it generalize to the classroom? That's the point of the whole thing, right? Not can they come in and do better on a test. And it's mixed. So meaning that sometimes it works and sometimes it doesn't. It's not that, oh, it doesn't work or it always does, but it's not a clear home run. Interestingly, physical exercise is, particularly radiotherapy, is thought to exert neurotoxic effects through suppressing cell proliferation in the, for example, hippocampal region, which has to do with learning and memory, and frontal cortex, which is about self-guided, self-directed behavior, and reducing the potential for neuroplasticity in existing brain circuitry. So exercise is known to support cell proliferation and is well established in promoting neural environment that's amenable to plasticity. So that was a precursor to Don Mabbitt, a colleague of mine at Toronto Sick Kids, had a bunch of brain tumor and leukemia kids play, of all things, floor hockey, which makes sense in Canada. But 3 times a week for 3 months. And it was just break a sweat. It wasn't like do hard cardio work. It was just breaking a sweat. They demonstrated an increase in processing speed and memory. It wasn't statistically significant because it was a small n, but it increased, which is encouraging. And which I find fascinating, they did MRIs pre and post. The size of their hippocampus, which I was mentioning to you, has to do with learning and memory and consolidation of memory, actually grew and matched waitlist controls, and also healthy controls, and continued to grow 3 months post-intervention. So it's a really potent intervention. I think it's important. Compliance, however, with exercise-based interventions may be of concern as survivors of childhood cancer report very low levels of physical activity. So one thing we're going to do at Memorial is have tracking bands that we'll give to a patient and to a family member to turn into a family intervention where they'll be exercising, and some kids will get positive messaging, some won't. But the point is, it's really important to turn it into a family intervention, not just, why don't you go for a bike ride, why don't you do this? And you need to lead with them as well. And I'm hoping you keep this in mind when you're thinking, should I go to the gym? I'm tired, let me just go home. I want you to try to exercise for yourself as well. So in terms of medicine, a couple of things I wanted to say to you are that Ritalin was initially studied. It primarily improved processing speed and aspects of attention during a very short randomized trial. But what's really important to notice is that 45% of pediatric oncology patients benefit as compared with 75% of ADHD children. So that's clearly saying that those who go through treatment for cancer, their brains are working differently than a healthy kid who never was sick. And we don't fully understand why that is, but just it's not the magic pill. Being male, being older at treatment, displaying more ADHD symptoms, and being less neurologically compromised and higher IQ before you took the medicine was often predictive of a positive response. And then I just wanted to show you one other medicine is Modafinil. It's Provigil. It's an anti-narcolepsy medication. It's approved for adults, but it's not approved for children. We tried to study this at COG because you can see it focuses in the hypothalamus, the proposed sleep-wake center, as opposed to amphetamine and methylphenidate. So it has a much different activation. It binds to dopamine, a modest activity, improved wakefulness. Adults who've had brain injuries, many use it, many swear by it to get through the day, to be vigilant, have the energy to focus. We tried to see if it would work for children. And what I wanted to show you is that it was a 6-week drug trial, randomized. The key parts I want to share with you are 57 out of roughly 250 sites open to study. So that's saying to me, and hopefully to you, that it was many sites didn't open it at COG. And then of those that opened it, only 27 started recruiting. And then 95 enrolled, 86, because it's 2 parts, you actually see if they have attention problems, and if they don't, you say, have a great day. If they do, then you offer them the placebo versus Modafinil. So 86 were randomized as having attention problems. That's 90%. But guess what? And I completely respect this, but it's a little challenging, a little frustrating. You'll call parents, what? Medicine? My kid has been on so much medicine. Thank you, but no thank you. Click. Or a handful, my kid's already is on medicine now. But I try to explain that it's not, we're not saying go on medicine. We're saying we're going to screen your child first in a high percentage MET criteria. And I will say that medicine is not for everybody. But if your child is struggling in school because of variable attention concentration, it's worth a try because they pee it out. Within a week to 2 weeks, it's crystal clear. It's not, whereas if you and I took anti-anxiety or you and I took antidepressant medication, it takes a couple months to get it to therapeutic dose. It's not like that at all. And it's a science and an art. So they start off conservative, and then they slowly creep up in dose. You could say, oh, my child is not sleeping. Oh, let's cut it back. My child comes home and can't do their homework. Okay, let's give you a little bit in the afternoon. Or my child doesn't like the way it feels, gives them a stomach ache. Okay, let's try this medicine. So you're not going to hit it perfectly out of the from the get-go. But if it's significantly impacting your child's functioning, and we can cure it with not just medicine. This is not about medicine only. There's plenty of books and plenty of behavioral recommendations we make. I just want you to be open-minded about the opportunity. So because of that, the study closed early because we struggled to recruit. We're trying to see what the data shows. So future directions are a few-fold. One is I'm actively, and other people are actively looking at who are at highest risk, because not everybody develops learning issues, not everybody develops social emotional risks. So who are the highest risk groups based on things like genetic polymorphisms, inflammatory markers that you get from CSF, advanced MRIs that look at functional connectivity. And I'm really excited to try to narrow down who is at highest risk so that we can go after them early and in a targeted way. But to that point, what do you go after? Do you go after attention to remediate? Do you go after memory, processing speed, academics? It's unclear what the target of the intervention is. Also timing, theoretically earlier is better, and I agree with that. But right now St. Jude has a consortium study where they're doing exercise during treatment, and it's falling flat on its face because these kids are just, there can be a too early. So the question is, do you do it during treatment, right after treatment, or in survivorship? And what components do you use? Do you use computer-based, medicine, exercise, parent training? There's a whole bunch of slides I didn't put in about parents that we can talk about at another time. And which personnel to provide. Medical staff, do they have a role? Do parents have a role? Like I was saying about the bands that the parents wear as well. School, if exercise is helpful, then why do we tell kids, oh, you are on adaptive PE, sit on the bench? Maybe they shouldn't do that. Maybe they should be exercising, stretching, doing yoga, doing some activity. So I just want to check our time. It's 10:55. I went over the cognitive. I have. Okay, cool, perfect. Because I just want to remember how I said social emotional is just as important. I don't want to just talk about cognitive. So I have a handful of slides on psychosocial. So I'll be clear, and we have about 5 or so minutes left. Most studies that look at survivors of and quality of life, parent report, teacher report, self-report, say these kids go back to the classroom and they're just like their peers, they're indistinguishable, which is fantastic, and that's what you want. However, there's a subgroup around 10 to 20% who suffer long-lasting social emotional difficulties, trauma-related psychological distress and deficiencies in social competence that can result in isolation from peers. And research has demonstrated the impact of physical late effects. And I know that brain tumors is a clear example, bone tumors, insults to CNS, but I would suggest also that those kids who have high-risk neuroblastoma, who wind up having hearing issues and other speech issues and growth and hormone issues, absolutely fit this subgroup, not all, but for the physical late effects that function and functional impairments. And again, you know this all too well, but just to concretize it and put it on the screen. So more internalizing disorders than externalizing, so it's much more withdrawn, socially isolated, somatic concerns, lowered leadership ability, lowered self-esteem, lowered intimacy with peers. And these are hugely problematic. And I'm not suggesting standing here saying we have the answers for everything, but it first starts with identifying the problem and then testing out interventions, which we do have, on how to assist. So just to also be mindful of, under quality of life, there's a physical aspect, treatment effects, functional well-being, school performance, social with peers, relationships, families, and emotional coping and distress. It's not just like there's no one IQ number. There's no one number for quality of life, like it's good or bad. It's multidimensional, and they're all equally important. It's just a handful of maybe few slides of people who've looked at quality of life of neuroblastoma survivors for you. A comparison of quality of life between parents and patients treated for Wilms tumor and advanced neuroblastoma didn't detect a significant difference in overall IQ between those two groups, although neuroblastoma was slightly lower. There was a significant difference with increased deficits in hearing and speech of neuroblastoma as a consequence of the platinum-based chemo, which we discussed and you know all too well. Heterogeneity of treatment for advanced neuroblastoma makes conclusions difficult, but morbidity is greater and more variable from earlier regimens with intensified treatments. Thankfully, you've heard yesterday about new advances in treatment and less neurotoxic. So the field is growing quickly, and it's encouraging to lower the toxicity, improve survivorship, and minimize late effects. And what's equally impressive is your aptitude, your awareness, and your knowledge of all these aspects. Yesterday, I was blown away by you guys getting up and asking all these really detailed questions that I could tell you that most brain tumor parents and leukemia parents are aware of, but not to this degree. This is so much more complex and novel and confusing. And you guys are, kudos to you to being on top of all this. It's really very impressive. A different study looked at health-related quality of life questionnaires that were mailed to 432 adult survivors. That's why I wanted to include it for you, because that's a very healthy number, and 654 adult survivors of Wilm tumors. On average, survivors reported no decline in physical in this particular study, but both groups, Wilms and neuroblastoma, scored significantly below norms on the psychological aspect of the quality of life, reflecting decreased emotional health. And independent risk factors included, again, who's at highest risk, because you want to know who is at highest risk so we can go after them early for support. Turned out to be, in this instance, female gender, Native American race, unemployment, and a household income below $20,000. Thank you. I appreciate your attention. And bam. Wanted to see if you had any questions. Thank you very much.
Does anyone have any questions? Yep, we've got one here, and we've got one there. So,
Hi,
all right,
thank
we'll go
you for
there
that. That was
first.
really good. I'm Catherine from Australia. My older son, who's not in treatment, has ADHD, and he's on Vyvanse for that. And so it does definitely run genetically from the other side of the family.
Happy Mother's Day.
Definitely. So my question, I suppose, is I've taken Ryder with his older brother to the paediatrician and just sort of as an aside said, you know, do you see any signs of ADHD in him? And he said no, because just for a few things that he was observing in terms of that. So my question just is there a chance that the treatment could develop ADHD in him or attention problems and things like that? And so should I look at getting him tested for working memory and things, and if so, when? Because he's just turned 4.
Right. Those are excellent questions. A couple of things are IQ tends to be more stable once you hit 6 or 7. However, the IQ starts, there are many measures, but the Wechsler, which is the most commonly used, starts at 2.5. Mm-hmm. So once your child's 2.5, I think it's really important to not just look for, to get someone tested, not just for attentional difficulty,
Yep.
but to look for their learning profile. And it serves as a baseline, so to speak. A true baseline would be before someone has an accident or an injury or an illness. But as a baseline, because he is going to be growing and changing and developing over time. And so roughly every 2 years for an older child should be tested, every year for a younger child. So yes, I think your child should be tested. Will they develop attentional difficulties? Not necessarily from the treatment once it's over. What does tend to happen is if they have attentional difficulties and slow processing speed, they tend to fall further and further behind over time, and then it becomes harder to close the gap. Yeah. So late effects do emerge further out, but attentional problems per se don't crop up later. The last point I just want to say is that I also think testing and diagnosis is important, because using medication or being recommended is a touchy subject for parents. I get it. And my really brief description is that you could be inattentive for lots of reasons. You could be inattentive because you're anxious, you're depressed, you have a math disability, and you're like, I have no idea what the teacher's saying, like, I'm just not going to pay attention. You have a language disorder, so it's too many words, you fill up like a sponge, you live in a shelter. So if you are tested and you have attentional difficulties on multiple measures that indicate it, then I would make a recommendation that it's worth talking to a psychiatrist or a neurologist to try the medication. So that's a long answer, but I think it incorporates many aspects of what you're saying, that yes, I think your child should be tested now as a baseline. No, I don't think that they'll develop attentional problems later because of the medicine. And if they do have attentional difficulties, it's worth trying medication, because you'll know fairly early on and it runs in your family, so it's better to be
And look,
thorough.
I would say, and it took me probably a year and a half of being involved in another support group for ADHD parents to come around to the idea of medication for my 6-year-old. Has absolutely changed our life. It's changed the family dynamic. He came home on the second day of having it and said, I don't get in trouble at kinder anymore, and my friends will play with me. And so, I'm an advocate for it now because I can see how much it changed. And I think had his father come across that, it may have changed the whole path of his life as well. So,
Right.
That's my experience anyway.
Thank you for sharing that, and I try to express that to parents that when it works, it's like, oh my God, is this my child? Why didn't I do this 2 years ago?
If that hadn't happened before I had to be in hospital with Ryder because I'm a single parent, the stress of leaving him with someone else for an extended period of time, especially overnight and things like that, would have just broken me, I think. So.
Right. Yeah, thank you very much.
No worries.
Okay. Do we have one more question, I think?
Linda from California, from Los Angeles. Couple questions with IEPs. My son is 5. He just turned 5. Never has been in school because he was diagnosed at 13 months old and still in treatment. But anyhow, I'm looking to put him in school now because he finally reached starting vaccines soon. Are IEPs required in the private school setting, or is that just public schools?
So that's an excellent question also. IEPs are not required in private school because they're not mandated to follow it per se, but your property tax dollars go 60% go to paying for public school. So two things come to mind. One is that not all private schools, not all parochial schools, but some allow Board of Ed people to come into the school based on the IEP. So it would be helpful to have it because you can get services either in, again, for people who have kids in Jewish day schools or Catholic schools. They can push in Board of Ed people. Or alternately in a private school if they don't, or in the Catholic school if they don't, you can get it in the community, either at the public school or in the community, get a related service provider and say, I'm going to take my child to OT or PT in the community, and please kindly pay for it. Truth of the matter is, you may have to supplement what you pay for the OT, PT, speech and language person, but the point is your dollars are going towards these services, so you could either get it in the private school or the parochial school or in the community. So I would encourage you to get it because it gives you guidelines and recommendations, and the private school may not be mandated to follow it, but it gives them really specific goals, and the neuropsych testing will have specific recommendations. So the testing and the IEP are all important aspects, even if, to answer your question, your child's in a private school. And that makes me think of one last thing is, in the olden days, which didn't seem that long ago, but you had to prove that the Board of Ed messed up, and before you asked them to support a private school education, to fund it, to redirect your money to private school. But now you don't have to prove that they can't meet your child, that they messed up. That you just have to prove that they can't meet your child's needs. They're not equipped to meet your child's needs. An example of that could be your child has reading difficulty, and they don't have a qualified reading program or reading specialists. And they say, oh no, but public school says, oh no, we'll put you in a small classroom, but those small classrooms have kids who are behaviorally disordered and acting out. No, my child is not like that. I don't want my child in there. There's excellent LD schools, even though your child is perhaps LD for a different reason because of the cisplatin, because of the hearing loss. You want your child to be in a LD school. You advocate for exemption to have the Board of Ed pay a private school funding. And you may know this already. If you don't, I want to share that with you, that I'm not sure if you've advocated and gotten the Board of Ed to pay for the private school, but that's an avenue you can go down. I hope I was clear with that.
Yeah, I didn't know that, so I will look into that.
Absolutely. It's your tax dollars. So.
Yeah, exactly. My other question is regarding that software. How can someone just get that software, the CogMed or whatever it is?
Right. So it comes with a caveat that it may or may not work. But you go online at CogMed and you would sign up and pay a fee for it. Alternately, to speak to your hospital where your child is being treated.
MSK.
Oh, at MSK. Yeah, we don't have.
I was wondering if it was through like seeing you and then you set them up on it or something.
No. It's independent. What I was trying to do is in LA maybe. There's a COG study using Cogstate. That last one that had 60 people and I said only 10 involved. There's a subset of hospitals that are recruiting for that. So I was saying for you, for like CHLA or something, to see if they has a COG study in your site where you could do it for free, as opposed to paying for it. That's my only thought. I'm happy to help connect you because there's like 10 or 12 or 15 hospitals in the country that are doing that CogMed, so it would be free for people who live in those areas.
Okay, great, thank you. Thanks.
Okay. Last question, because we're way over.
I don't know if you can answer this, but so I have a 14-year-old survivor, went through stage 4, all the nasty stuff when she was 5, 6, has the processing and working memory issue down. So we've tried Vyvanse, Focalin, maybe one other. Do you know if there's what's the best drug out there for working memory and processing skills?
Yeah, I wish that there was a optimal drug and that I knew which one was best for your son. I'm glad that you're open to trying alternatives. Also, we need to operate within our areas, scopes of expertise. So as a neuropsychologist, I defer more to a psychiatrist or neurologist. I think it would probably be a combination of things, and one would be behavioral. There's a book that I recommend in most of my reports, 10 Lessons Medicine Can't Teach. That's on Amazon. That's won all these parent awards and has nothing to do with medicine. It's exercise, nutrition, diet, structure. That's 10 lessons medicine can't teach. Being in a school that helps your child is open to kids who have those difficulties, and whether it's the current school or finding a different school that's smaller but private that works with them developing those skills. And I wouldn't purport to yell out a name of a medicine, but I just would say that Modafinil is worth asking your doctor about. I said that it's not authorized for children, and insurance companies try to reject it at first, but most parents and doctors advocate and then they authorize it. And I'm not saying it would work, but it's something to ask about.
Thank you, Dr.
Thank you very
Sands.
much.